A 2020 study published in the Journal of the American Geriatric Society analyzing data from the national inpatient sample from 2012 to 2016 highlighted the significant impact of dementia on healthcare expenditures in the U.S., primarily due to increased rates of hospitalization. The study, which included 1.8 million unique hospitalizations of older adults over 65 with diagnosed dementia, found that out of an estimated 9.27 million hospitalizations, 40.1% were for potentially preventable conditions, including acute and chronic ambulatory care-sensitive conditions and injuries. Ambulatory care-sensitive conditions are those that can be managed with high-quality outpatient services, things like pneumonia, urinary tract infections, and falls. Despite a slight decline in all-cause hospitalizations over the study period from 2012 to 2016, potentially preventable hospitalizations rose, particularly among community-dwelling older adults, indicating a growing need for improved early detection and management of conditions to prevent hospitalization. The study also noted an increase in healthcare costs associated with these hospitalizations, from $7.4 to $9.3 billion annually, and underscored the lack of national policy initiatives specifically targeting the reduction of preventable hospitalizations among this vulnerable population, despite existing programs aimed at broader healthcare improvements and injury prevention. With this sobering backdrop of rising hospitalizations and healthcare costs for older adults with dementia, let's dive in to today's conversation with our esteemed guest, a seasoned occupational therapist and dementia consultant, to explore effective strategies for navigating these challenges and improving the care and quality of life for those affected. Welcome to Aging Together, a podcast dedicated to exploring the challenges and opportunities of caring for our aging communities. I'm your host, Dr. Pooja Ashok Patel, an occupational therapist with specialty certifications in geriatric care, dementia, and fall prevention. In this podcast, I interview guests who are experts in their fields or can share their experiences with caregiving. Together with the guest speakers, we dive into a wide range of topics, including health and wellness, care planning, caregiving, and more. I hope you'll join me on this journey. Let's navigate aging together. Hi, everyone. I'm your host, Pooja, and you're listening to Aging Together. This month, we're bringing back a guest from last season. Rachel Wiley is an occupational therapist and the founder and owner of Dementia Consulting and the Dementia Collaborative. Rachel is certified in Skills to Care for caregivers of individuals living with dementia, and she is a certified dementia practitioner. She is also a certified master trainer of Skills to Care through Jefferson Elder Care and trains other occupational therapists in the Skills to Care program. If that's not enough, she is also currently a volunteer advisory council member for the Dementia Society of America. Recently, Rachel published a book titled Promoting Participation, Engaging Individuals Living with Dementia in Meaningful Activities, which can be found on Amazon. Together, we're diving into how you can navigate challenging situations and health-related crises with persons with dementia. Please join me in welcoming Rachel to the show. Hi, Rachel. Welcome back to the show. Thank you so much for joining me again today.
Thank you so much for having me, Pooja. I'm so excited to be back.
All right. Introduce yourself. I provided a super brief bio, but I love your passion for what you do, and I'd love for the audience to hear it from yourself.
Thank you, Pooja. I'll just give you a brief background on what I do. So I am an occupational therapist. I am both a dementia consultant and a dementia educator. So I have two businesses. One is called the Dementia Collaborative. That entity, I mostly train other healthcare professionals in dementia care. We're possibly expanding some offerings to support care partners, family care partners as well. But for the most part, healthcare professionals. And then I also have dementia consulting, previously called day-by-day home therapy and day-by-day dementia consulting. And that is where we offer one-on-one family consultations. So supporting families who are caring for someone living with dementia with some of the most challenging aspects of care, trying to break down those challenges, figure out why they're happening, and hopefully come up with a solid game plan and action plan with strategies to make that easier. So that's me in a nutshell.
Oh, I love everything that you do about this. And I love how passionate you are about just everything dementia. And I'm so excited to hear about everything you're going to say today.
I'm going to try to keep it brief, but I can't promise.
Yes. For the purposes of our audience, let's do a super quick introduction to dementia care. Could you start by giving us kind of an overview of like unique challenges that persons with dementia might face, or especially like when it comes to healthcare navigation and challenges, health issues, things like that?
Absolutely. So this might be a hard thing to kind of talk about extremely briefly, but if I'm kind of thinking as an overview, so we know that dementia itself is a group of symptoms, right? So dementia can be caused by a variety of different conditions or diseases, Alzheimer's disease being the most common cause of dementia. But dementia itself being this group of symptoms is comprised of things like memory loss, changes in what we call executive function. So some of those higher level cognitive processes. So things like planning, sequencing, judgment, safety awareness. We also see changes in the ability to possibly do math, changes in language, changes in behavior or socialization. So again, all of these things grouped together, we call dementia. So most commonly, the people I work with who are living with dementia and their families, most of what we're tackling are changes to function, meaning we're seeing changes in how someone maybe is able to get themselves dressed, or maybe difficulty getting bathed or using the bathroom. We also see dementia-related behaviors. So some of the most common behaviors might be things like resistance to care or help, resisting bathing, repeating, agitation, anxiety, waking up at night, wandering or pacing. We also see things like rummaging, hoarding, hallucinations, delusions. Again, not an all-inclusive list, but these are just some of the behavioral challenges that might come up as well. So when we think about hospitalizations, sometimes those hospitalizations are triggered by some of those behaviors, but also, even if they're not, we do have to consider how someone with dementia is functioning and what maybe behavioral challenges they're experiencing when we think about that hospital stay and experience.
Yeah, absolutely. I have seen a lot of times in the hospital, someone gets brought in because of agitation, or it's becoming more difficult to take care of them because they're resistant to that care, or they're becoming violent with their agitation. And, a lot of that is just really learning how to create calming environments and addressing those behaviors, right? But that's a whole separate topic that we can get into for hours.
Absolutely.
So let's talk about myths. What are some that you've heard or are constantly trying to educate families on when it comes to dementia?
Another great question. So there's so many that we could talk about. I think the first one that comes to mind when I think about myths in dementia is that if someone has dementia, life is over. It's all doom and gloom. And I want people to know that, yes, dementia can be extremely challenging, and I'm not trying to discount all of the challenges that come along with dementia, but just because someone has dementia doesn't mean they can't live a meaningful and beautiful life. So I think that's probably the biggest message that I hope people will take away when they think about myths. Other things that come up, maybe less broad, but things like, the person with dementia, they're so stubborn. Oftentimes when we talk about dementia, the person is not intentionally being stubborn. They're not intentionally trying to make our life more difficult or challenging. They're experiencing changes in their brain that lead to some of these difficulties like resistance. And so it's really a matter of trying to meet them in their world and their reality so we can try to make their life easier and also make our lives a little easier as care partners.
Absolutely. Let's talk a little bit about the role of occupational therapy. So you're an occupational therapist, I'm an occupational therapist. How do we approach working with, or how do you approach working with dementia patients, persons living with dementia, to improve their quality of life, particularly during health crises or hospital stays?
That is a really interesting question because I think often when people think of occupational therapy, even our colleagues, when they think about what we do or what our role is, people may think pretty concretely about what we call ADLs or activities of daily living. So they might just think about how we can support with bathing, dressing, grooming. But our role as occupational therapists is much broader than that, especially when we think about dementia care. So yes, we can support individuals living with dementia and their families and care partners with those ADLs. But our role is also we really specialize in activity analysis. So it's being able to take a task or an occupation, as we call it, an activity, and break it down and figure out, where are the challenges and how can we adapt the environment, the activity itself, the task, the objects, and or our communication so that we can create or facilitate more engagement or function. So by that, I mean, if we're thinking about a hospital stay, for example, someone living with dementia who came into the hospital, possibly, let's just say for a urinary tract infection, maybe they're feeling extremely agitated, anxious. We as occupational therapists, yes, we can support that person with things like getting dressed and bathing and eating. We can also think about what is the impact of the environment on that individual's agitation? What is the impact of our communication on their agitation? And we can help make adjustments to the environment to create a more calming and peaceful environment to help reduce the agitation, again, for that individual's quality of life and ideally the care partner's quality of life throughout the process as well. So I know that's a very specific example, but again, we can adapt environment, adapt tasks, adapt communication, and all of which will hopefully enhance activity engagement and quality of life.
Great, well-rounded overview of what we can do.
It's hard when our profession is so broad to really try to break it down. And again, I think another challenge is that oftentimes, even as occupational therapists, we think we're pigeonholed into one particular aspect, but our job really can be so much broader.
It's true, especially in the hospital. I know we're going to jump into hospitalizations a little later, but I can speak to my experience just being in the hospital on the inpatient side for 7 years. It's one of those things that we do get pigeonholed because that's what discharge planning is looking at. That's what insurance is looking at. And yes, they really just want to make sure if they can do their ADLs. And there's so much more to it than just the ADLs, right? And so It's really difficult to kind of be inclusive of our entire scope and everything we can offer when you're limited in time, you're limited in resources, and there's a lot of patients to see, right?
Yeah, that's it. There's so many systems at play that make some of this work challenging, but we do have the capacity to do a lot. It's just a matter of, does the system support us to do all of those things?
Absolutely. So in your experience, what is the most difficult part of being a caregiver for persons with dementia? So a lot of that we're talking about kind of tends to fall on the family caregivers, right? Whether it's a spouse, a parent, a child, every so often, maybe it's a friend, but generally they're family caregivers. And so what's the most difficult part that you've seen?
I think I have probably a couple answers to this as well, but the first thing I think about is the difficulty of losing aspects of that family member, loved one, person living with dementia. So as they decline throughout the dementia progression and different aspects of maybe their personality or their function are declining, oftentimes families, those caregivers and care partners are experiencing a sense of grief. And then the kind of compounding factor, the additional factor here is not only are they experiencing grief, but oftentimes they're also experiencing guilt about their grief because their family member is still physically present with them. In those circumstances, and again, this is most individuals are experiencing some degree of grief and may or may not be experiencing guilt about the grief. I usually recommend that people, seek out counseling services. There are so many great wonderful counselors. I know it's difficult with accessibility depending on insurance coverage and cost if you're paying out of pocket, but it can be really helpful to try to process that with someone who is qualified to support you throughout that. I think in addition to that, in terms of difficulties that care partners face, again, we could go on and on for days on this topic. But the other kind of big thing I'm thinking about in relation to the topic we're talking about today is the maybe disconnect. I don't know if that's the right word, but disconnect or sometimes lack of knowledge from other healthcare professionals. And I don't say that lightly because I don't want to throw our colleagues under the bus, but it is one of the reasons I started doing this work is when I was, seeing my grandmother with dementia and realizing how limited the healthcare team was in their understanding of dementia. I felt like as a family member, so much of my role was advocacy and education to healthcare professionals, which was exhausting. And I would think that there are probably a number of families who are listening to this feeling as though the advocacy that they have to do is such an exhausting and tiring part of their role as a care partner. Again, I could talk about that for days, but I think maybe we'll leave that one for now.
I 100% agree with you there. I think part of this, and again, like you said, we're not throwing our colleagues under the bus here, right? Like it's hard. Healthcare providers at large are trained to be generalists. They don't have specific knowledge of specific care diagnoses to then be able to adapt and adjust their way of treatment for specific clients or patients, right? And so that's where specializations come in, right? That's why you have within physicians, you have specialty providers, right? Within therapists, we have specific specialties. And there's a reason for that because we're trained to be generalists. And that's why it's important to, even on that front, though, what I do urge our colleagues to do, though, is be mindful that there might be things that you don't know. Yeah. And if there are people who are a little more trained in certain areas, then being open to that feedback and being open to implementation of that feedback for the betterment of the client or patient, right?
Absolutely. And to that point, Pooja, I mean, of course, I don't want to put any additional burden on care partners. And also those of us who do dementia care, we recognize that family care partners are the experts on their family member. So even though, yes, I like to think I know quite a bit about dementia, at the end of the day, that family care partner is going to be able to give me insights into that person living with dementia that I wouldn't have otherwise. So, no, I don't want to put additional burden on them. But their viewpoint and their experience and their knowledge of this individual is crucial to be able to provide adequate services.
Yeah. I started this episode with some statistical background and information on just persons living with dementia and hospitalizations. And a 2020 study found that there were nearly 9 million hospitalizations of people diagnosed with dementia. And I think they were looking at data from 2019. And that's not as shocking to me, but they found that nearly a third of them, so almost over 3 million of those 9 million patients, their hospitalizations were potentially preventable. So we know that preventative care is crucial for everybody, right? You do that work, I do that work. We're in it for the proactive and preventative care, right?
Yes.
But it's especially important for those who are living with dementia. What are your top recommendations for preventing unnecessary hospitalizations for individuals living with dementia?
Oh my gosh, this stat gets me so feisty because I think about, individuals living with dementia, hospitalizations are traumatic for anybody. But when you have an individual living with dementia who benefits from consistent environment, consistent routine, familiarity, hospitalizations are really not ideal. And to know that a third of them are potentially preventable, it's just, that's a lot. There are so many things that we could potentially consider in terms of trying to reduce hospitalizations. I think we can talk about it from like a behavioral standpoint, and we can also think about one of the biggest things from my perspective when we think about changes in cognition or changes in behavior. People will often ask me, like, how do we know that this is, quote, just dementia related? Is this part of dementia? Or is this some underlying medical condition that's manifesting in this new behavior challenge? My rule of thumb is typically, is it an acute change, meaning a sudden onset or change of behavior or function. So if someone who typically was agitated, they're not typically restless on a regular basis. And then within the span of, a day, a couple of days, we're seeing this individual is now extremely agitated, restless. Maybe we're seeing other behavioral changes. To me, that's an indication that, okay, we probably want to, it might not be an ER visit, it might not be a hospitalization, but we at least want to get that person into the physician, to the doctor, to see, is there an underlying medical condition that is contributing to this change in behavior or function? With dementia decline, yes, dementia, is progressive and we see general decline. We typically don't see a sudden acute change in behavior with dementia if there's not something else contributing to that. So those would be some things to kind of look out for, to say, okay, we've noticed this kind of sudden change in mom's behavior, personality. This would be a good time to get into the doctor and not wait for this to get a lot worse, where maybe we potentially do need a hospitalization. Other kind of crises that may lead to a hospitalization include, again, some of those behavioral manifestations. So maybe, again, I'm thinking of just some of the more common ones, but extreme agitation, possible aggression. We can also think about falls. That's another kind of subset of this. But if we think about behavior, typically what we like to do as occupational therapists, or really anyone in the dementia space, we're trying to figure out, how can we, A, reduce the behavior from happening, and B, try to manage the behavior a little bit easier or better when it does happen. This is also probably a topic I could talk about for hours and hours, but if I give kind of a general summary of what are some strategies, what are some things to look for to try to reduce some of these behavioral challenges, I think about 3 main categories, and some of this work comes from Mary Corcoran, Dr. Laura Gitlin. They talk about this triadic model where we have kind of 3 main categories, if you will, of possible triggers or causes of dementia-related behavior. And that includes what's happening within the person living with dementia. How are they feeling? What are they experiencing? That could be things like, are they feeling a sense of loss of control? Are they feeling scared? Are they feeling nervous, anxious? Are they experiencing a side effect from a medication? Are they hungry, thirsty? Do they need to go to the bathroom? Are they constipated? There's all of these potential things happening within that person that they might not be able to articulate. So we need to do a little investigating and digging in that category. We also want to look at the physical and social environment. So is the environment possibly triggering or contributing to behavior? Do we have maybe a really overwhelming or overstimulating environment? There's a lot happening. And so it makes it more likely for mom to get agitated and react. It makes me think of a client I have right now who resides in a memory care community, and she was experiencing some physical or more verbal aggression with the risk of escalating to physical aggression. And so much of it was triggered by being overstimulated. She didn't have the ability to give herself or initiate her own breaks when she needed it. So it really came down to the staff being aware that this was a need and being able to facilitate the break for her. So after lunch, being able to bring her back to her room, give her a calm, quiet space before rejoining the group for activities, right? So environment plays a really big role in behavior. And then the third category being communication. So how are we communicating? That includes our verbal communication, it includes our nonverbal communication, and all of that could potentially trigger behavior as well. So I know this is a very long answer to your question, but really thinking about how can we adapt, again, the environment, adapt our communication, and do some investigating to think about what's happening within that person with dementia. If we're really thoughtful about all of that, we can implement strategies that are customized to that person that can help reduce some of these escalating behaviors, which can help reduce hospitalization.
That was a great answer. And each of those can be their own topics.
Yes, that is the truth. I could talk for days on all of that too.
I know you can. I know you can. So shifting focus a little bit to like, okay, now they're in the hospital. Something's happened and they're in the hospital, right? In my experience as an acute care OT, working primarily with these older adults, oftentimes with cognitive decline or diagnosed dementia, I did a lot of work with fall prevention in the hospital. And these were often the most high risk patients, right, for us because we couldn't use the same strategies and education that we used with our other patients, right? We can't tell them, hey, make sure you call for the nurse before you get up. They're not going to remember, right? Hey, make sure someone's with you when you get up. They're not going to remember. General like alarms, sensors, things like that could overstimulate them and actually increase their risk for falling, right? Because let's say they're pretty mobile and physically they might be okay to get up and walk around, and we're not concerned of them falling from a physical standpoint, but more so from a cognitive and environmental standpoint, right? And so,
Yes.
and when we put sensors on them and they go to get up, and there's this high-pitched scream coming out, right? Because the alarm goes off because they got up without asking for help. Now we've overstimulated them and maybe potentially even startled them, which could increase their risk for falling, which they may otherwise not have, right? So there's all these little nuances that play a role when we're working specifically with our persons living with dementia in the hospital. So I guess, what are your thoughts on how families can kind of prepare for that in advance or kind of have a game plan? And then what about healthcare providers? You know, I kind of looking at some of those environmental adjustments, but also some of that, what you talked about with like adapting communication strategies and adapting the environment and adapting kind of what the needs are.
This is a doozy of a question, Pooja. It involves so many aspects. I mean, so important for us to talk about these things. So you bring up multiple fantastic points, but the idea of, alarms and sensors, the idea of even, ambulatory devices. We know that giving someone living with dementia a gait aid, like a walker or a cane, can actually increase their risk for falls. There's, again, so much nuance in when and when not to use a walking device for someone living with dementia as well. So many different things we have to think about, not only, again, for the healthcare professionals, but also for families to really consider all of these specifics for the person living with dementia. If I'm going to give kind of just some more broad or general tips here, the first thing I think about when I think about fall risk specifically in the hospital is meaningful activity engagement. So one of the kind of biggest triggers, if you will, to getting up, to walking around, to pacing in the hospital would be they're possibly anxious, they're scared, they're in this new environment, they don't know, 100% where they are, what's happening. And so there's this kind of innate or internal drive to just, I've got to get out of here, got to get up, I've got to move, I've got to do something. So if we can kind of mitigate that a bit by giving the individual living with dementia something meaningful to engage in, some sort of meaningful activity engagement, we can reduce the likelihood that they may be pacing, wandering, trying to get up out of bed. So what do I mean by meaningful activity engagement? That might look different for everyone. For some people, it might be, listening to their favorite music that they can sing along to. For others who have the ability, it might be doing something like knitting. For other individuals, it might be, sorting some playing cards on their tray table. So it really can depend based on that individual's preferences, what they like to do for fun. For others, it can just be meaningful conversation, right? Just reminiscing, telling stories, anything to kind of distract or redirect from the current situation and environment of being hospitalized. So I think that that's probably the biggest kind of intervention or strategy I would think about would be some sort of meaningful activity engagement. It still doesn't answer the question of eventually they're going to need to get up and they're going to need some support. I think this is really where multiple healthcare team members, it's important for us to all kind of communicate and be on the same page in terms of, is the physical therapist recommending a walker? Well, what if the occupational therapist thinks that cognitively that's not a good fit? Again, we previously talked about some of the challenges for families and care partners. Healthcare providers not being on the same page is probably another challenge that they're facing. So for any healthcare professionals who might be listening, I would advocate for all of us being able to communicate consistently with each other about what our recommendations for that patient and that family are, so that we're all consistent in our messaging and can really figure out what the safest way to ambulate or walk is. For some people, it might be hand in hand. For some people, it might be a walker. For some people, it might just be, there's someone else in the room with them providing supervision to make sure that, they're not scared or upset. So those are just a few things that we can consider in terms of family preparation. Again, I know this is a really hard thing to think about when, you're possibly quickly transitioning into a hospital setting. But if you possibly are prepared with a few activities in your bag, simple things that you can kind of pull out to engage the person in, I think those are going to be some of our best friends in these circumstances.
Yeah, you mentioned a few things that made me think of a couple things myself. Just the meaningful activity engagement reminded me of a patient one time who, she just, the family eventually told us that she likes to stay busy. She doesn't like sitting in a spot or anything. And so, we kind of asked like, okay, what kind of stuff does she do at home? And so they're like, well, she's constantly cleaning or doing laundry or, putting stuff away. And so we literally got like our linen cart and just gave her like a bunch of towels. And we're like, can you help me fold these up, please? Right. And like it made them feel like they had something
purposeful
to do. And it's like simple things like that where, at first it was like, oh my God, they keep getting up. We don't have enough eyes. Like, what do we do? And it became just one of these things of like, okay, can we figure out like why they keep getting up? What do they need? And then giving them something to do so that they're not feeling so bored, right? Boredom's a big thing too. We don't talk about that enough. When just even thinking about, like you said, the breaks, we need breaks, right? And we can take them when we need them. They can't do that. They don't know when they need a break. Same thing when they're bored. They want to get up and do something, but they can't verbalize it. And so we have to do that further investigation to find out what's going on, right?
Yes, 100%.
The second part that you mentioned was team members being on the same page, right? Mm-hmm. This happens a lot in the hospital. And it kind of comes back to, again, it is exhausting for the families to advocate for their family members. But it's really important for us to all communicate. I can say like, I'm very proud of and grateful for like the team that I worked on because we all did communicate. And it was one of those things where, just like you said, if PT thinks that they might need an assistive device, but we know that they don't typically use one and they have an advanced level of cognitive decline and they're likely not going to be safe with it, we can have that conversation and brainstorm ways to help that person move safely, right? It's not one or the other. And then similarly, then being able to relay that to the nursing team who then, is hesitant to get this person up now because, PT thinks they need a device. OT thinks they don't need one. Well, we don't feel comfortable getting this person up. So now we're going to make them stay in bed. Let's think about all the consequences of what that can lead to, right?
Exactly.
And then even going further with that, oftentimes that can then result in mismatch in discharge recommendations too, right? Because my PT colleagues and will agree with me on this or like shared the same experience where like we'll have communicated and we'll have decided like, okay, yes, this person's not the safest moving around. Yes, this person's not the safest for living at home alone, but they're safe enough to go home with family members, right? And the family members have identified and informed us and showed us that they can safely take care of this person at home. But then the medical team is concerned about everything because they're looking at just the patient, right? And not the entire family and environment. And they're sometimes then saying, oh, no, this person can't go home. And they want us to send the patient to a rehab facility or a nursing facility. Also, that becomes really important, right? And we keep talking about communication. And communication can be particularly challenging, especially when we want to also involve that person living with dementia as best as we can, right? So I guess what strategies do you recommend for healthcare professionals and also family caregivers to effectively communicate with not just the person who is living with dementia, but with each other to make sure that we're providing the best and most appropriate recommendations?
There's probably a lot of layers to this answer as well. I think my first thought when we think about the involvement of the person living with dementia in terms of communication and how much we are telling them maybe about their condition, about their hospital stay, I am a big proponent of weighing the pros and cons of providing the person with that information. So for example, if I tell them they're in the hospital because they, have a hip fracture, is that going to massively increase their anxiety? That will lead to constant repeating, nervousness, difficulty sleeping because now they're thinking about that. Or when I provide that information, does it give them some sense of security, some sense of control? They, retain that information for a period of time to make them feel involved in their own care and care decisions. So part of it is really teasing out, the significance or severity, if you will, of their cognitive impairment. So, do they have mild dementia? Do they have moderate dementia? Do they have severe dementia? And also, again, this is where the advocacy for the family comes into play. Based on their experience, is this someone who is likely to have anxiety or an anxious response to that information? So that's really helpful information from the get-go to know, am I going to have these conversations directly with the person living with dementia, or most likely, many of these conversations about the current stay in the hospital are going to be happening not directly in front of the person living with dementia. And I say that with respect to the person living with dementia. I don't want to exclude them from their own care. Rather, I want to prioritize their quality of life. And so if we are having these conversations that are upsetting them, that's not benefiting them directly. So first thing is to consider, do we need to have these conversations behind closed doors, out of earshot of the person living with dementia? Of course, we still need to communicate in some capacity to the person living with dementia. That might be for things as simple as, making sure they stay hydrated, making sure they're taking their medication, supporting them with, again, back to their ADLs. So when we think about communication, there are lots of different strategies we want to consider. I'm usually a big fan of trying to think about how the environment or the objects in the environment, or even us as people, how we can communicate without the use of words. I say that because some of us, meaning myself, can be very chatty, use a lot of words, and that can be really hard to process for someone living with dementia. So if I, for example, try to work with someone living with dementia and I try to go in with the idea that I'm going to help this person take their medication, but I'm going to try not to use words, that way, when I do choose to say something, I'm much more thoughtful about the words that I'm using. So I'm thinking about it beforehand. I'm choosing only to use maybe a couple words at a time. And then also when I say like using the environment or using the task, what do I mean by that? So some, just a very simple tip that works for a lot of people. Let's say, for example, I am trying to get the person to drink more. Could I say, take a drink. I need you to drink this water. Sure, I could say any of those things. Is that going to result in the person drinking more water? Maybe, maybe not. What I prefer to do is, have the cup of water in front of the person living with dementia, maybe even place it in their hand. I have my own cup, whether it has water in it or not, doesn't really matter. And then I say cheers, right? So I put the cup up, I'm making a gesture, cheers, and then we can both take a sip. So I kind of mime sipping where I actually take a sip if I have my own fluid. Using different strategies or simple communication strategies like that allows the person to feel more in control, more involved. We're not telling the person what to do. We're including them in a process of, hey, cheers. This is a social activity that we're doing together. We can use the same strategy for taking medication, right? Pills for you, vitamins for me. Cheers. Drink our water, put our pill in, drink our water. Again, I know this isn't going to work for every single individual living with dementia, but this is an example of a simple way that we can adjust our communication to support that person living with dementia. And I think the second part of your question was also, how do we as the support team, care partner, the healthcare professionals, how do we communicate with each other as well? I don't know that I have a perfect answer for this one, but I think the best thing I can recommend is consistency in approach. So, for example, if the family knows, mom is triggered by this word, if you say dementia in front of her, that's going to really upset her. Or when you take her to the bathroom, if you say, time to pull your pants down, that's going to really upset her. If the family is able to communicate that with the healthcare team, and then they take the responsibility of making sure it's communicated among each other, among the nursing staff, the rehab staff, we are going to facilitate a better stay, a better experience for that person living with dementia, because we're minimizing the potential triggers for behavior. Yeah, I think healthcare staff, Pooja, you probably could expand on this better than I can from your experience in acute care as well, but possibly even having a healthcare professional, make a note in the chart about certain strategies or things to avoid or things to consider when communicating. What do you think about that?
Yeah, absolutely. Depending on what EMR system is being utilized, there's usually options to leave notes, interdisciplinary notes in patients' charts. This was actually a project that a PT and colleague and I actually worked on together with nursing and actually revamped our internal documentation system, where a lot of what we were recommending was getting lost in translation, right? So we, OT would do their assessment, PT would do their assessment. We'd inform the nurse as a handoff. Maybe we'd write it on the board, and then, it would just get passed on, right? And it gets lost in translation at no real fault of anybody, right? It's just a game of telephone at that point, and it just keeps getting moved on, and things change, right? With dementia, it's like what might worked yesterday might not work tomorrow, or, you did it this way yesterday, but maybe you can't do it this way today.
Right, exactly.
And so sometimes, in the hospital, we don't see patients every day, depending on what floor they're on. And so what we may have recommended on Monday was no longer appropriate on Wednesday or Thursday. And
great point.
So there was this huge disconnect between what therapy was recommending, what we had relayed to nursing, and then how the patient's hospitalization course was impacting that. And that was specifically difficult when we were working on cognition and falls. And so a PT colleague of mine and I actually did a performance improvement project where we looked at how we could improve that communication between therapy and nursing. And so we found that we were documenting on similar topics, right? So OT would be documenting on cognition and mobility, PT would be documenting on cognition and mobility, and then nursing would also be documenting on cognition and mobility. But there was no overlap of who was making which recommendations and why they were recommending it, right? So now the system has all this different documentation of all these different recommendations of how to help this person stay fall-free and help with cognitive management too. So what we did was we figured out a way that when we were doing our assessments, we would provide interdisciplinary intervention recommendations. And so we'd identify our assessment, the interventions that we implemented as the provider, as the therapist, and then recommendations for the interdisciplinary team. And what that did was then that when nursing goes to document under their cognition and mobility sections, they actually got a preview of what OT and PT were recommending. And so they were able to then guide their decision-making based on some of the recommendations we had been making. And so I think it was a way to decrease that risk of information being lost in translation.
Yes.
But also we made sure to make it only a 24-hour carryover, right? Because if we're making recommendations on Monday, they might no longer be appropriate on Thursday. And so then it still falls back on nursing to make that appropriate call. A big piece of the cognitive piece here was kind of what you said with the environment. So I think as generalists, we learn like delirium management is lights up during the day, lights off at night, right? Windows up during the day, windows closed at night. Loud music or like loud noises during the day, quiet at night, right? To help facilitate some of that sleep-wake cycle. But if somebody's not following that at home, if they have a nap routine at home, that interrupts that routine in the hospital then, right? If they're already in a different environment, but now they've have a different routine that's being impacted. And what we would find is there was often times when somebody, and I can talk about this forever because it drives me up the wall, but there would be times when somebody living with dementia is hospitalized and they have a UTI and they're agitated, right? Because they're uncomfortable. And they're in this environment that is very highly stimulating, right? Hospitals are so stimulating. They're loud, they're bright, they smell, there's so many people. And that generalist mindset is to go in every morning and make sure that the blinds are up, the TV's on, the doors are open. And these people get so stimulated, overstimulated, which then leads to agitation. And the way that they were managing it was medication, right? That's like, okay, let's calm them down with medication. And that was a point where I was like, can we try other things first? Like, I think they're overstimulated. Like, let's close the blinds, turn off the lights, let's turn off the TV, close the door, get some warm blankets on them and see what happens. Right.
Exactly.
And so it was even things as significant as that, where there was a lot of miscommunication or just general lack of awareness and knowledge on how to manage those kind of differences or changes that come with hospitalizations. And so we could now make that as a recommendation, right? Like hyperactive or hypoactive delirium in the hospital.
Yes.
What do you do for that, right? If they're hyperactive, you want to calm them down. If they're hypoactive, you want to stimulate them. How can you stimulate them? How can you calm them down? These are all things that we as OTs are very well positioned to make recommendations for once we've done an assessment for the patient, but also had a conversation with the family, right?
Yes.
Like, what are their home routines? What helps calm them down? What helps stimulate them? Because they would know better than any of us could ever know from an assessment in like 20 minutes, right?
Yes, yes, yes.
So, along those same lines, a large part of my job in the hospital as an occupational therapist includes patient advocacy, whether it's identifying and asking the team for additional consults, referrals, collaborating with social workers to assist the patient and their families with community resources if we identify that they need them. How does this differ when we're working with patients with dementia and their families? Like, what types of support systems and resources do you typically recommend for family caregivers to help them manage both their loved ones' needs, but also like their own well-being?
The really crucial piece of this question, Pooja, that you said is working with patients living with dementia and their families. So the biggest piece is the family has to be considered in discharge planning, in resource guidance. We talk in occupational therapy about how a typical kind of rehab mindset, if you will, thinks about the patient. Dementia care, which we consider more habilitative, thinks about the dyad, meaning the person living with dementia and their counterpart who is providing much of their support. Again, typically that's a family member. So hopefully the family had some support and resources already in place even before a hospitalization. So we want to make sure that they are set up to be able to resume whatever services or supports they had in place beforehand. So for example, if they had non-medical home care in place and some form of respite in place, the fact that this individual living with dementia is now in the hospital, we want to make sure that services can resume as soon as they're back home, that there's not going to be this lag of a couple weeks to get reestablished with that agency or that individual to provide that respite. Again, whether that be non-medical home care or possibly, an adult day program, those types of services. If they haven't already been accessing those types of services, it would be really valuable to at least have conversations about what respite looks like, what type of support they can get in place in home. So whether that be, again, non-medical home care, adult day programs that provide some level of respite, whether it be in the home or outside of the home, we also want to think about what continued healthcare support is possible. So is that Medicare Part A home health? If they don't qualify for that, is it possibly outpatient therapy provided in the home? From my perspective, the best place for an individual living with dementia to be would be in their home. And when I say home, that can be their community dwelling home. It could also be possibly an assisted living as their home. There are many locations that we can talk about home, but home is going to be the best place for that individual because, again, we talk so much about this concept of consistent environment and routine. We want to get them back to that consistent environment and routine. So anything we can do to facilitate that is ideal. And again, a lot of times that looks like healthcare coming to the home to help support that family with transition. And also, in addition to that, I could, again, talk a whole other podcast on caregivers taking care of themselves and making sure that they're getting the right supports and resources. But whether that be support groups, whether they're physically going to a support group or calling in or Zooming into a support group, or if they're not, group people, if they'd prefer that one-on-one support, again, of a counselor, a therapist. There are a variety of therapists who do specialize specifically in care partners of people living with dementia, and many of whom may even take insurance as well. So any sort of resource to support that care partner with their mental health, with their physical health, they're going to be really important considerations in the plan.
Absolutely. So now we're getting ready to leave the hospital, right? We've covered getting into the hospital and then being in the hospital. After a hospital stay, the transition back home can be challenging because the transition into the hospital was challenging. We figured out a way to make that less challenging. Now we've got to take them back out of that environment and get them back home. What steps should caregivers take to ensure that that is a smooth transition?
So again, I think kind of the theme of our day today is, consistency, consistent environment, consistent routine. So anything we can put into place to facilitate that consistent environment and routine. I know that's not always possible. For example, maybe somebody had a fall and when they're coming home, they now need their bedroom to be on the first floor. Maybe they now have a hospital bed in the living room when that wasn't the case before. If we can do everything in our power to make that environment look like what they were previously used to, that's going to support them. So can we create a bedroom feel in the living room if those are the circumstances, as one example? But if, they're going back to the exact same environment, anything we can do to, again, maintain that routine is going to be crucial. You talked about even things like sleep routine, nap routine, familiar activity engagement, familiar meals. It can be tricky. We talked about this idea of maybe having the healthcare team coming in to support the individual in the home. And while that's often necessary, that can be overstimulating if we have all of these different healthcare professionals in and out of the home for, a period of time after they come home. So if that's the situation, I would recommend, as many breaks as possible. So it might mean that the person needs more sleep, more rest, more naps, more downtime. It may also be, reasonable. You talked about this concept of stimulation, being overstimulated in the hospital environment. Typically, the home environment is less overstimulating than a hospital. But again, anything we can do to facilitate a calm, peaceful environment. And we talked about that idea of boredom earlier as well, or the benefit of activity engagement, even if they're simple activities. Yes, we need breaks, we need rest. And if there's a lot of downtime, we can support the person with simple, calming activity engagement.
Yeah, that's a great piece of advice. We definitely try to relay that to family caregivers if we have the opportunity to before somebody's leaving the hospital, but it's not always possible.
Yeah, it's hard.
Have you noticed any cultural differences throughout your experiences with working with different individuals? Do different families kind of navigate or want different levels of recommendations or insights from providers when it comes to dementia?
Yes. I think that I'm going to talk very broadly about culture, or I guess maybe this is niche family culture. But the idea of each family really has their perception of what they view for their own family member living with dementia. So for some people, they think that means being scheduled every single minute of every single day. And that's what they want care to look like. I had a family one time where I appreciate everything that they were going for, but they had trips to every day there was an outing, whether it be to the zoo or to get a haircut or to go to an aquarium or to take a walk in the park. They had all these pretty big activities planned every single day. And the rest of the day was also packed with activity. So culturally, that's what they were used to. They were used to a very busy, planned, full schedule. So it was, educating the family on, yes, that may have been something that they previously enjoyed, and that was their previous lifestyle. But with dementia, we do have to consider alternative ways of supporting them. That's going to be, again, reducing some of that activity, engagement, and stimulation. We also have, if we think kind of some families really want more prescriptive interventions, they want you to just say as the clinician, here's what you should do, here's what you should not do. Others are much more interested in being a collaborative piece of the puzzle to really develop those strategies individually. I've also worked with some individuals where maybe, they viewed dementia as a manifestation of something that the individual did in their past life. And then this is culturally like a representation of that. And I'm not articulating that very well. But I remember this one individual who it really took a lot of kind of, I would call it like Dementia 101, like really kind of educating them about, this is not that person's fault. The individual has changes in their brain. They did not bring this on intentionally, but also being respectful of whatever their religious or spiritual beliefs were prior to the onset. So sometimes that's a tricky balance to try to meet in the middle. I don't know if I answered that question the way you were thinking, Pooja. Do you have any thoughts on that question?
Yeah, no, I 100% agree with you. And I like how you broke it down into kind of that generalization of, you have some families, and this kind of goes for all families, right? Not even just family caregivers of people living with dementia. You've got some people and their families who want to just be like told what to do, right? They're trusting you to be that care provider and trusting that you can tell them what to do and that they'll do it and it'll work, right? And then you want some who are like, don't tell me what to do. Like, I want to be a part of this, right?
Yeah.
It's really different, I think, and specifically when it comes to dementia, because it's really up to the family to decide for the patient, right? It's also like for those who generally like to just be told, like, here, do this and it'll work. It's not necessary that what we tell them to do is going to work. And so I think it becomes tricky then to work around that cultural expectation of like, well, you're the expert. You tell me how to address this. I will do it. And if it doesn't work, I don't trust you anymore. Right. And so that gets tricky with dementia because we don't know what's going to work. What might work for somebody might not work for somebody else. This isn't like, oh, you have a bacterial infection. Let me give you an antibiotic and it'll fix it. Right. We can't fix dementia. We can't fix behaviors. We can't fix challenges that come up with dementia. And so I think it's a difficult situation to navigate.
I think that's such a great point. Sometimes I use the phrase informed trial and error. I feel like dementia care is informed trial and error. There is a reason that we are trying certain strategies, but at the end of the day, each person's unique, each circumstance is unique, the environment's different, the people surrounding them may be different. There's so many factors that are either going to facilitate success with a certain strategy or not. So there has to be some level of adaptability, some level of trial and error when we think about dementia care.
Yeah.
As hard as that is.
It's like calculated guesses, right?
Yes, exactly.
Like, I'm just guessing that this might work because it's shown to work, but it might not work for this person.
Exactly. That's it. And like, there's research that backs up the process, but any of the research we look at in the world of dementia care, you will find that anytime I'm speaking with very broad strokes here, but anytime we see research that is testing one specific intervention, there's typically not really great evidence on its effectiveness in people living with dementia because one specific strategy is not going to work for every single person. The most effective research we have out there is programs or, providers who are using a problem-solving approach, who are saying, okay, in this circumstance, based on all of these factors, we're going to customize and try this strategy. That's really what we know from research is what works in dementia care, but it does make it really hard because we just want an answer.
Yeah, absolutely. I have so many more questions here that I want to review with you, but we're at time. And so for the sake of time, what is one takeaway you'd like the audience to consider as it relates to everything we've talked about today, from dementia to family caregivers, communication, hospitalizations, health challenges, kind of whatever you feel is like a big takeaway from everything today? And I know that's asking a lot.
One takeaway. Okay, I'm just going to go based on kind of the theme that came up today. So even though I'm sure I'll reflect on this and be like, there's more takeaways. Okay, I'm going to say today, the biggest takeaway is people living with dementia typically thrive when they have consistency in their environment, their routine. And when we as care partners, whether that be family caregivers or healthcare professionals, are advocating for the individual needs of that person living with dementia. So customizing the environment, the task or activity, and communication to support that person.
You can write your own textbook definition with that.
I love it.
Rachel, thank you so much for this wonderful conversation and in sharing our joint passion for educating the public on all things dementia.
Thank you so much for having me. It's always a pleasure speaking with you. And I know you and I could talk about this for forever. So thank you so much for giving me the time today to chat about one of our passions.
Absolutely. To my listeners, thank you for tuning into this month's episode with Rachel Wiley. If you would like to learn more about Rachel or Dementia Consulting or the Dementia Collaborative, please visit rachelwileyot.com. You can also find her on LinkedIn at Rachel Wiley or on Instagram at dementia_OT. Sharing expert perspectives on various age-related topics and services can help the community learn how to plan for a healthier future. At Aging Together, we are dedicated to helping you navigate aging together. Thank you for tuning into Aging Together. This podcast is brought to you by Aging Together LLC, a private care consulting practice helping individuals and families age with a plan. This episode was produced by me, Dr. Pooja Patel, in partnership with Natural Eye Media. If you found this episode of Aging Together valuable, we'd love your support in spreading the word. Your likes, shares, and reviews fuel our mission. Don't forget to rate and leave a review wherever you're listening. Your feedback matters. Until next time, take care.